All right, so why don't we do the roll call the meeting to order.
Dr.
I'm guessing that's me, Kier. You just cut out there for a sec.
Dr. Broderick,
Here.
Dr. Daly,
Here.
Dr. Durso,
Here.
Dr. Curran,
Here.
Dr. George,
He was on an overnight. I don't know if he's going to be on this afternoon.
Dr. Gerling,
Yep, here.
Dr. Katz, Dr. Laporte, Dr. Mulvey, Dr. Pond,
I'm here.
thank you, and Dr. Williams.
Yeah, here.
And then Patty Bashaw
Here.
and Pam Trout.
Here.
Okay, and we do have a quorum.
Thanks, Zach. So we'll get the meeting started. First thing on the agenda, review the previous meetings minutes. Anybody want to make a motion? Or do we want to review them?
We'll make the motion.
I'll second.
Okay. All right. All those in favor?
Aye.
All those opposed? All right. So meeting minutes approved from our previous meeting. We want to move on to the med standards report. Dr. Bombard. Anything from the CMAC?
No.
Okay.
We have not had a meeting, and they canceled. We were supposed to have a meeting this Wednesday, and they canceled because they have snowflakes down south, I've heard about. So yeah, there's no nothing.
Okay. Same for the SEMSCO, I'm assuming?
That is correct.
Okay. All right. DOH?
I believe Director Greenberg is actually on the call.
Oh, welcome.
Hey everybody, I am here. Happy to answer any questions and anything else, but nothing specific to report out on. And yes, they had some snowflakes downstate. They're just not used to so many snowflakes. That's the problem.
So many all at once. Yeah.
Exactly.
Okay. Well, thank you for joining. Appreciate you being here. Anybody have any questions for the director?
Me, pick me.
Tiff, you got a question? Sorry. Oh, yeah, you got your
I
hand up.
do. Ryan and I have been talking about services becoming ATS services. So services that can transport blood and blood products as interfacility transport. This is not the 911 blood project. That's a totally different project. And this was previously administered by the Wadsworth. It was sort of this long, difficult process to get approved, but there was a process. We are, and I don't know if Tom, you are having the same sort of problems. I know Maddie, you are encountering some of this. We are having trouble because we don't always have nurses to send from Messina, Alice Hyde, Adirondack, places like that, right? With blood products, and we have these devastatingly injured patients and no surgeon and very little blood product on site in these small hospitals. And so we would like to be able to send our patients from small hospital to large hospital with a paramedic administering blood products. So this has been a conversation that Ryan and I have been having recently, and Ryan's been working on it, but I think that it's of interest to the region. I wanted to have this discussion with all of you anyway, so it's kind of a great forum. And I was wondering, Ryan, where we are with the project.
Yeah, so part of this is waiting and to understand what happened. So when blood became available, or blood moved the statute from pre-hospital blood being able to be administered by an EMS agency, the statute moved both the ability for EMS agencies to carry blood, as well as ambulance transfusion services, which was for the longest time with Wadsworth, the clinical lab division, over to EMS. And they moved it over. However, they in the process didn't move over kind of the regs and things that come behind it. So we have to put the regs in place in order to really formalize it and formalize the process. And so so Tish came to me and said, you know, hey, this is Tiff. It was like, you know, we have these services. I was like, well, nobody's really reached out. So we've had some that have reached out and said, I want blood, but not necessarily too many on the ambulance transfusion side. So she's like, well, I have names, because Tiff always comes with, you know, the specifics, which I appreciate. So we've reached out to those as well, and there's definitely some interest up there. So we are working with our legal affairs. The regs are predominantly written, but have not gone out for public comment yet. Once they go out for public comment, it becomes a little bit easier for us to have that process. But we are working with Division of Legal Affairs right now to determine a process while that isn't in place to essentially mirror similar to where the regs will state, but will give us a temporary fix, and then the long-term fix would be they would have to be compliant with all the regs that come out, which reality is any temporary fix that we do would align with anything that the other, you know, that the regs would as well, unless something gets changed in the regs. So like, let's say it goes out for public comment period, and in public comment period, all the physicians say, well, you have to have a red stripe on the front of your ambulance if you're going to possibly carry blood, then that could change it. You never know, right? Like stranger things have happened. And so that, you know, then they would have to comply with that additional reg as well. So that is where we're at right now. We're working with legal affairs to determine what that short-term fix is for our immediate critical areas. We have asked areas or agencies that don't have an immediate urgent need to hold out for the regs, but those areas that do, or agencies that have it, you know, hey, there's a true need in this, then, you know, we will work with them to figure that out. And so that's the process where we're at right now. I'm hoping in the next month or so to have an answer to that. And then once it gets approved, the process, I don't think will take long, because we're really talking about a handful of agencies. We're not talking about, you know, 50 agencies that want to come forward and do this. And it would not be to carry blood as an agency. This would strictly be on the ambulance transfusion service side. We're going to hold off on anybody carrying blood until at least the public comment for the regs come out.
So, I mean, one thing that I kind of pick up on, you know, I think that there might be more agencies out there that would be willing or eager to be able to transfer blood, because we rely on not just one agency for our transports from Albany, for Glens Falls to Albany. We rely on a lot of community agencies to help with transport. So at least one and probably a few are going to look into becoming that level of transfer where they can do blood products. So
Yeah.
Is there like a time frame that these temporary regs might be showing up? Like, is this like a 6-month thing, a 2-month thing? Is there any time frame where we can look at that?
So I think we're going to have a short-term fix, you know, hopefully in the next 30 to 45 days in place. And then once the regs are out, even for public comment, it becomes a little bit easier and cleaner, and kind of from that point, realistically, the regs for public comment will come out sometime this summer would be the goal. And then depending on how many times it has to go out for public comment. So, you know, if it goes out for public comment and nobody says a word, then, you know, they'll be out by the end of the year. If it goes out for public comment and there's a number of revisions that need to happen or things of that nature, then, it would have to possibly go out for public comment a second time. So then you're looking probably, definitely the end of the year, if not beginning of the following year.
So I have two IFT agencies that are been kind of waiting, and I have to say my ops team has been kind of trying to do all the paperwork and things like that. What can I tell them about anything they have to do specifically, what we have to kind of work on, how we can start carrying blood? Because yeah, I agree with Tiff. We're in a scenario where it's definitely indicated it would help the patient. Like, what do we need to do?
When you say talking about carrying blood, you're talking about interfacility
Sure.
blood, correct?
Yes, continuing to, that we're not
Okay.
actually, I'm sorry, we're not carrying the blood, we're continuing an infusion.
Yep. Yeah, and that's an important one too, right? So like, it's one of those to try and always remember, like, oh, we're trying to continue, blood that's been already started or stuff like that. So I think if you reach out to me, send me an email or things, I will connect them with our branch chief who is overseeing kind of this fix with me, and we're happy to work with them as well. Like, we'll add them to the short list. If they're not names, are those names of agencies that you already gave me, or is this addition to? Addition to. Okay, yeah, great. No, I got it. I can read lips on occasion.
Is there a way you could
Sorry.
send that? Could you give us that information? Because I have agencies, like I said, that would be interested as well. Could we get that sent to the group, or is that possible?
So yes, but I would stress again, it is a little bit of a better fix for us to try and not go every agency under the temporary fix, and to wait, essentially the 6 months for the public comment period to come out. But if there's a true critical need in an area, then, let's get those agencies.
We could be judicious with that, but we're kind of in the same boat as Tiff. Even at Glens Falls, we don't have oftentimes we're relying on, there are one or two that do the primary bulk of our additional transports, and they do a high volume. So, and that's one of the agencies that's kind of approached me about doing the interfacility blood. So, I understand what you're trying to say without overwhelming the system or getting everybody in under the system. But, if we could, make sure that the ones that we need are there, because, we do have a need at Glens Falls, even though we're kind of not as rural as some of these other guys.
Absolutely. And like you said, you have a high volume agency that's doing a lot of it and really has a need.
Mhm.
Those are the agencies that were saying, hey, let's do this on
Yeah.
the short term and work on, many others on the long term.
Awesome. Thanks.
And also, you can refer any additional questions or workload to Patty Bashaw. She's volunteered to do all the work of the pre-hospital blood analysis, and she's going to review all applications before they come to us and directly work with each of the people that would like to do it. So thanks, Patty. Really appreciate that.
That we were friends.
New liaison. Good.
I'm really glad I didn't get just thrown under the bus for that. Patty, I'm glad you're here.
No, but, and Jonathan, I will throw you under the bus on one side of it. The more that the programs, when they submit their paperwork and everything else, look similar, the better it is for everybody involved, both for those providers who work in multiple agencies that are doing it, as well as for us as we're reviewing documentation. So, this is one of those opportunities where if there's a regional template or framework of saying, hey, this will meet the bulk of what everybody's looking for, you should consider using this. This is what we use in 2 other agencies. This could be, a prime example of where that becomes beneficial for everybody involved.
Cool. Well, thanks for that update. That's super helpful. Anybody else have any questions or issues? Otherwise, we'll move on to the next topic in our agenda. Everybody good? Okay. All right. Thanks very much for that update. We appreciate it.
Yeah, my pleasure.
Gonna do Jonathan or Zach, the program agency reports.
Yep. So the PowerPoint was sent out. Really, we just have the ALS operating authority renewals that are specific to you guys. Dr. Pond, I do see that you're trying to get your camera on and it's not working for you. It's okay. Although I haven't seen you in a while, so I just was worried that something was wrong, but you're here, so I'm not so worried anymore. So the ALS agency operating renewals, Zach, if you want to go ahead and pull up the PowerPoint for those. And I will pre-apologize. I know that there is typically the data that Dr. Pond has requested, and I know there is great value in that, and it is not on the agenda. We will send that out after the meeting. Zach's been a bit buried with regional skills and getting that all inputted. So it's not that we didn't want to, it just didn't happen, and it will happen, and we'll make sure it happens in the future.
I guess the biggest thing I'll say, main update from this is we did get the medical director form here for Covington, so I did update that here. So they're pretty much, that was their biggest hang up there.
Are you
So they
screen
should be all
sharing?
set. No.
Thanks.
No, you have to watch.
Yes, we did receive Fort Covington's MD form this morning. So can you go back? Thank you.
Yeah, and then the other biggest things, I guess, here was a couple of them are their medical directors to Dr. Daly. And then so work with them. So again, just usually we would do a 3-month extension type of thing for them. Fort Edward, we got most of their stuff, but not everything. And then one of the things that we didn't get to from them was the medical director form. So that was a recommendation for a 3-month extension for them. And then Long Lake, I actually talked to Tony Catalfamo earlier, and he pretty much just kept sending us the same state DOH medical director form and not actually completing the Fountain Lakes medical director form. So we have like 3 of them signed by Dr. Laporte within the past couple months that are the state form, just not our medical director form. So that's, he wasn't on the attendance earlier. So I guess that's up to you guys what you want to do with him, but maybe a 3-month extension for them, or the rest of their paperwork is there. So that's up to you guys.
Okay. I don't think we need to go through each agency individually. What I thought about doing for this was for all the full 2-year renewals, let's vote on them as a group. And then the changes to Dr. Daly, we can include in the full 2-year renewal, or we can separate those out if anybody wants. Then we can vote on the extensions, and then the 2 from sorry, Zach, the Covington, sorry, did you clarify, is that all good to go? It's still in red, but it
Yeah,
says
I
MD.
didn't, just because I wanted us to know that we changed it. So that was the only thing we needed was the director form, and I got that this morning. So yes, Fort Covington could be in with the 2 years.
Okay,
That would be fine.
so really the only one is the Long Lake. So why don't we start with this? Can we just do all the full 2-year renewals, vote on that as a group? And is everybody okay with including the changes to Dr. Daly in the full 2-year extension and doing all those as bulk? Sound good? Okay. All right. Can I have a motion to approve all
I'll
the
make the
full?
motion to approve the 2 years and the change to Dr. Daly.
All right.
That's
Thank you,
Doug Gurley.
Doug.
I'll second that.
All right. All in favor?
Aye.
Aye.
All opposed? Don't hear any opposition. All right, so those all get 2-year renewals. So now the next one we'll tackle is the Long Lake. What do we want? So Zach, the bulk of those extensions, are those going to be 3-month extensions? It doesn't say except for Fort Edward.
It's up to you guys. I didn't hear back. The ones at the bottom that were extensions, I didn't hear any communication back from them as far as renewing.
Okay.
Uh,
Why can we do a 3-month and then hopefully we hear back from the agencies. That'll give us time to contact those agencies and follow up.
I'm fine with that. And then we can chat with Fort Edward along with then Long Lake too, and we can just do one more.
Anybody want a longer or shorter extension, or are they okay with 3-month?
Is there any reason we can't use the state form for the Mountain Lakes form or vice versa? Are they that different for Long Lake?
Typically, we would use the Mountain Lakes one at the forwarded motion from the medical director. So that's.
Oh, I got it. Okay, it's the medical director one. Okay.
Yeah.
Sorry.
Otherwise, realistically, the state form has probably a lot more information on it than the Mountain Lakes one does, but the Mountain Lakes one is the specific forwarded motion from the medical director. So.
That's fine. I got it. I didn't understand.
Okay. All right, so everybody's okay with a 3-month extension for everybody needing an extension.
I'll make that motion. Second.
Okay. Okay.
I'll second.
So everybody in favor of providing a 3-month extension for all those from Fort Edward down to West Glens Falls? Anybody opposed? And then we're including Long Lake in the 3-month extension. So Long Lake, Fort Edward, all the others, no one opposed? Okay. All right. So everybody else gets a 3-month extension. All right.
The next thing that would be the most applicable for you guys is the supraglottic airway implementation for BLS practitioners, which I know Dr. Bombard wanted to talk about, and I do have a slide for that, Jeff, so we can go from that. So right now, the process with the state is that they have to submit a med director verification form, agency policies, procedures, QA plan, and the training plan. That all gets submitted to the state through the state's fancy new portal, and then we get notified at the region of them doing that and get a copy of all of it, and then it has to come to the REMAC for approval. And then we have to submit a letter for you guys saying that you've approved it through the fancy new portal that we have to submit stuff to the state. And
So
now I'll shut up and.
Is this portal just the supraglottic specific? Or is this like a new portal for a lot of other things as well?
It's a new portal for us submitting any paperwork that we need to from the region to the state. It's going to be tremendously helpful,
Okay.
I feel.
Okay. But this URL is specific for supraglottics?
Yes.
Okay. And so any agency needs this DOH 4362 plus their procedures, QA, and training?
Yep. And I believe TIFF has more to speak on to some regional approach to this.
Yeah.
And just
I don't know how much I have
just to
to say, thank
clarify.
goodness.
Oop.
My understanding is that we as a REMAC need to forward a motion and vote that we approve BLS iGels for the region. And then all this stuff goes underneath after that vote. Is that correct?
Ryan is here, so I'm gonna let him chime in because I'm also not 100% sure on what the state wants our workflow to be.
Perfect.
I don't want to give you the wrong information on that one, so I'm happy to get back to you on it. But the one thing I did want to clarify, Tom, to your question too, is that when we talk about using the portal and it going to the region, that's an automatic. Like as soon as they hit submit, it goes to the region. It doesn't come through us. We look at it or anything else. So also recognize what goes to the region will be as much quality as what is submitted to go in. So if you ever get something and you turn and say, well, why did the state forward it to us like that? We don't filter it in between. It is just a pathway to navigate. And we have now done this with a lot of our processes, some of which used to only come to us, some which used to only go to regions and then come to us or whatever. Everything kind of goes through our portals, our portal system. And then within that portal system, we have the ability to, at the same time they submit to us, to submit to the region. So Jonathan might have some processes that don't need regional approval, but we still send it to them because it, like their annual renewals or things of that nature, biannual, that we want you to have a copy of the paperwork with. And actually, to be honest, it's one of those things where they turned and said, well, we want a copy of the paperwork. And I said, okay, great, we'll add you into the portal and you'll get a copy of it. Just recognize what you get is what you get. So that is just kind of part of that process. And then on the flip side, coming back, in why there's a portal now for submission of any program agency materials is things, either someone would change a job or someone's out on leave for some reason, whatever it might be. We had one of our staff members who just had a little baby, so like they're out for a couple months, and so sometimes things were getting submitted by the program agencies are like, oh well, I sent it to fill in the blank, and because they were out on leave, it was sitting in a mailbox for a period of time. So by going through the portal, coming back in, it streamlines all of that. If somebody's out, that portal's always being checked. It's just who's assigned to check it or things of that nature, and to move that forward on that front.
No, it sounds awesome. I think Patty's got her hand up.
And just correct me if I'm wrong, if they already got submitted through the pilot program, they're already good to go, correct?
So if they already got submitted through the pilot program, they're good to go to continue. However, I do believe the final determination was that they should resubmit their paperwork at some point, like in a timely manner, because just to make sure we have the most current, right? It went in through the portal. It was going to a region who was really doing the bulk of the work. So we just want to make sure we have the most up-to-date information on everything. So nobody, like, in some cases, if you weren't approved during the pilot, we say you can't start until all your paperwork's in. If you're approved during the pilot, you can continue, right? You were approved. We don't question that. But I do believe the final verdict was to have everybody resubmit at some point, just so that we make sure that, the file has all the most current information on it.
Tiff.
So I guess I was looking for corroboration, but my understanding, just to move us forward, my understanding when I left the last CMAC and we had decided, yes, that the BLS IGEL was going to be extended to all state agencies, was that it was going to be pending regional approval. So what we need to do today is regionally approve or disapprove BLS IGELs, and then our agencies can start getting this stuff together. Now, one last thing on this, it may be that we want to have a little working group as a result of this vote that comes up with some standardized policies, procedures, just to make our agencies' lives easier, but we don't have to do that. They can absolutely generate this one at a time all by themselves.
And I will add just one more thing to it is also up to the agency medical director. In other words, if they choose not to carry the device or don't want their agency to do it for some reason or something else. And then the one other thing, and this was kind of a further conversation, is it is only for licensed EMS agencies. So ambulance service or an ALSFR. It is not for a BLSFR. We are working on that, like heard loud and clear. We're going to try and figure out the pathways for that, but currently today that is not there. So it is specific to those two types.
And didn't I see, Tiffany, did you send something out already, like a start of a plan? I feel like somebody sent that out and it was a really good, I thought a really good stepping stone.
Dr.
Yeah,
Gurley
that's
and
the thing from
Steensboro
Doug
put
Gurling,
together.
actually.
Yeah,
It was Granville's work. I won't take any credit for it. So I forward Granville's plans and training and QA process, which look good to me. I forwarded as an example for the region to base any future stuff on if they choose to, but it had nothing to do with me.
so Tiff, do you want to, so the working group, we'll just take that packet, what Granville put together, send it to this committee, and then that committee can put it back out with any suggestions or recommendations or changes as a standardized protocol. Skeensboro's already developed it, so, or Granville, so they don't have to, change anything, and each agency can take it and do with it as they wish. But if they use that as the minimum standard, then we could put that out for everybody to use and add to as they wish.
Seems good to me. Do you want a motion?
A motion to approve IGL use for the region for BLS agencies, or for BLS providers,
that motion.
not BLS agencies.
Subject to medical
So-
director approval.
Correct.
Right, so
Which
a
is the way. it's
motion to
written.
approve BLS provider IGL use in cardiac arrest only, correct?
Yep.
This is only in cardiac arrest.
Mhm.
Okay,
So moved.
yes,
I'll second.
okay.
Just a quick question, Tom. And
Yeah.
so that is the preamble, but there's still going to need to be, and what Doug submitted, and I also did it with Cambridge Valley, training plan, documentation plan, things of that nature. So
Yeah, this motion only says that the region can move forward with this.
move forward.
In order
Okay.
to get certified for it, they have to complete all that requirement, the form, the procedure, the plan, the training, everything has to be submitted to us and the state before they can actually do this. But what we're saying right now is all the agencies can move forward with that process. So we had the motion and the second. All those in favor? Okay. Anybody opposed? Anybody opposed? Okay. I don't hear any opposition at the moment, so motion is approved.
Perfect.
Okay.
And then Zach, if you want to jump to the QA/QI or the quality and the word I can't say. Yep, the overall. Amanda, do you want to do it, or do you want me just to rattle through it real quick?
I can do it quick.
Okay.
So the 2025 CQI overall view, I'll only cover Mountain Lake stuff to save some time. So in Q1, we did 39 Mountain Lakes agencies, 174 charts. There were 4 agencies with no charts uploaded, 11 sent to medical directors. Q2, we did 38 charts. 38 agencies with 151 charts. 8 agencies with no charts uploaded, 2 sent to medical directors. Q3, we did 38 Mountain Lakes agencies, 167 charts, 3 agencies with no charts. 5 charts were sent to medical directors. Q4, we did 39 agencies with 148 charts, 9 agencies with no charts, 8 were sent to medical directors. Something I'm doing this coming year is splitting up which region the medical directors charts were sent to, because I didn't separate those, so I have no idea how many were sent to North Country and how many were sent to Mountain Lakes medical directors.
I will say though the to the ones that we have been sending out reports to that we've had issues, the response and the amount that the medical directors are involved, especially when they are Mountain Lakes agencies, is fantastic. You guys are actually taking initiative and saying, oh, this is a problem, let me work with this agency and make it better. And we are starting to see some changes in some relatively disturbing patterns that are now starting to swing back the other way, which is very nice to see. I
Dr.
know
Bomber.
Patty.
What criteria are you using to send charts to medical directors, just out of curiosity?
So I review the charts. I review all the charts. I flag charts that I think are concerning. We review them as a team, and then we decide whether we're just going to mention it in their summary that we send the agencies, or if we're sending it to the medical directors. Most of the time, if we're sending it to medical directors, there's something that the provider didn't do to, like, as treatment, or frequently lately I've been seeing charts with no vital signs at all. So those we've been sending to.
Like they'll write the narrative did vital signs, but then they don't document that they did vital signs. Patty, and then I'll answer Tammy's question. So the 9 agencies with no chart uploads, some of those are Vermont agencies, and they just don't pass they have to pass the Vermont schematron and then get uploaded to the New York State schematron. And there's just some kind of disconnect that Peter and his team are aware of, and they're working through that. And some of them are just incredibly low volume agencies. I'll use one here on the North Country side for an example, Wellesley Island Ambulance. They're an island in the Thousand Islands region that in the summer has well over 1,000 residents. In the winter, they're lucky if there's 200 people on the island. So they may get a call in a month. They may not have anything for a month, month and a half. So they'll flag as no charts uploaded either. Tammy.
Yes. Are we auditing the records based on any NEMSCLA criteria as well?
No, it's generally they're audited on completeness of documentation because PCRs are a legal document, and some of the stuff that some providers write in their charts is flat out scary. And that's really what the start of this was. We have had some talks of implementing some of the NEMSCLA standards. Once we get our feet a little bit under us again, after the start of the year, it's always a very busy season for us. That is something that I think we will definitely start doing.
So right now we're looking at if the chief complaint is documented, if the history of present illness is clearly documented, if the primary impression was documented, if there were 2 sets of vital signs, medical history, medications, and allergies, focused assessment, and did the treatment beat protocol?
And you'd be
so
surprised
some of
how
that,
many
though-
times you don't get a focused assessment on a respiratory patient and they don't document that they listened to their lungs or did anything.
So if you're auditing for whether or not the care provided met protocol, then you are at some level following NEMSCLA. I mean, NEMSCLA criteria is the patient is intubated and for a GCS lesson aid or things of that nature. So you're just probably not taking credit for that.
Sure. But that's all I have from the program agency side of things. Does anybody have any questions for the program agency? Again, we'll get that additional data that didn't make it out for this meeting. We will get it out and it will be included in the agendas moving forward again. And our apologies for that falling off.
Sorry, I had one quick question. So for some of these agencies that weren't submitting charts, if they weren't companies that just had super low volume, is there like any way that is being like having repercussions? Are the agencies being notified that they haven't submitted anything and so that they will submit for the next quarter?
So every month, Zach sends an email to every agency with the number of charts that were uploaded to the state bridge. And we ask that they check that against whatever the amount of charts they generated in their software vendor was to make sure that they are equal so we can make sure the state's getting all the charts.
We also make sure have the agency check with their vendor because sometimes so there's a certain 3-letter vendor in the state that you guys don't have on the Mountain Lake side, that is notorious for their charts not passing. We have an agency on the North Country side that runs 3,000 calls a month, and half of those maybe make it to the state bridge because of the software vendor. The state is aware of that, and Peter and his team are working to fix that. So when we do get agencies that don't submit, usually I send a message to Peter saying, hey, these didn't submit. They're checking with their vendor. If they come back to us and say that the vendor said everything is fine, then we know it's an issue between the vendor and the state. Or if now we have agencies that are buying into our regional platform. So that is one nice thing we've been able to do for some of the Mountain Lakes agencies is a few years ago, North Country was able to get a grant to offer its own image trend platform through the Coverdale Stroke Grant. So we're now able to offer that to Mountain Lakes agencies at a much better price than what a lot of other software vendors are offering. So we're actually able to troubleshoot that a little bit easier on our end now, if they're one of our agencies. But if we do our best and try to make sure that they fix their problems and work with Peter to fix it if it's on the state's end. I hope that answered your question.
Okay, yeah, thank you for clarifying that.
All right. QA reports by region. Do we want to just go by region, right? Region by region, or does anybody from the region want to make a comment? Because, you know, I don't know if we necessarily need to go through each agency or each region. Does anybody have an update that they'd like to share, or should we just move on to course sponsors? I'm not hearing any volunteers. In that case, I will presume QA is going well for everybody and we're all performing our duties. So let's go on to education and course sponsors. First one, Mountain Lakes. Anybody on from Mountain Lakes? Paul? Doesn't look like anybody's here for the Mountain Lakes education. So we'll go on to community college. Anybody? Okay. UVM. I saw Josh on here.
Yep, I'm here. Currently enrolled in our current cohort for Paramedic Originals. We have 33 students this year. We're probably going to run a condensed paramedic refresher. I've had a couple people ask, maybe a handful. So I don't have enough to run a standalone. They're going to run off our current Paramedic Original schedule. We're going to offer that over 9 weeks. I'm putting that into the state here ASAP. Hi, Ryan. Also looking to do a course during the summer, during the day for a Paramedic Original / refresher. With a possible agency asked if we would be interested in doing a CFR course, but that's about it as far as we're looking for major offerings around the area until our next year go around with another paramedic program.
Thanks for the update. North Country Community College. Anybody here?
I don't know if Scott's down in the basement. Zach? No? So I know Kirsten just finished up a course up in Saranac Lake. I think Scott just finished one up. I just finished one up in Keene. Everybody has tested the practical, I should say. And 2 more that were a little bit behind should definitely be able to test as well. So out of that whole class, I only lost 1 person, which I'm pretty proud of. We do have a course into the state for a basic EMT / refresher that we're just waiting for approval on. And we already do have courses running for the spring semester in Saranac Lake out of North Country. So we're moving along.
Excellent. Nice job. And Queensbury EMS. Is Ashley here? I don't hear Ashley. So, all right, we'll conclude the that component. How about minimum equipment regulations for ambulances under old business?
So the new regs will be going live in April. Those are the state regs. So we'll make sure we do some good marketing on our end to push out the stuff that is the new requirements for agencies to have on their ambulance. One thing that Gina from the state did make sure to bring up, and I'm gonna parrot this the best I can, and Ryan, if I butcher it, you can chime in, that the new regs don't go into effect until April. So don't go in compliance early because you're still subject to the old regs.
I would just add the asterisk there of don't go into compliance, but don't go out of compliance of the old regs. Meaning, if there's something that the old regs requires, but the new regs don't take it off your ambulance until after. Most of the stuff that's added, everybody has in their ambulance anyway. But like, and the part that kind of blows some people away is that like you weren't required to have an AED before, right? They all had them for the most part, but you weren't required to have it. And so like we thought that'd be a good thing to require. A lot of it really is, common sense and what many agencies have done already, but we do warn everyone, in order to stay in compliance. I will also tell you, if you get inspected or something else and something, is off or fill in a blank or numbers are off and things like that, then, we do recognize there's a little bit of a transition period, but, please try and be in compliance. We are working on some new 800 checklists as well. So for those agencies that, use our old school checklists for the start of their shifts and things like that, I do believe we're working on a modified one to put out to agencies that want to still continue to use something like that. But many have also moved to electronic systems and should be using that as well.
All right. Annual skills sheet. Is that Zach?
So I don't have the new skill sheet in there, but we discussed, Dr. Bombard had realized that we did not add the surgical airway. So that's going to be added for this year. So we'll make sure that we get that all sent out to everybody. Otherwise, no changes to it. The same, 12 hours required and all the same other skills.
Cool. Let's see. New business, we discussed IGL. Transvenous pacer management. That Dr. Laporte.
Hi. Unfortunately, Dr. Laporte is working clinically, but I asked Sam Smith to come and talk a little bit about this idea of putting transvenous pacers in the IFT guidelines. So she's here to talk about trials and tribulations with transvenous pacers and why we might want to think about adding them. Go, Sam.
Okay. Hi, I'm Sam Smith-Lau. I'm a paramedic with Saranac Lake Rescue Transport. We are, for the most part, all paramedics at our agency are IFT trained. And one issue that has come up over the past year is that we do take rather long ALS transports, and sometimes we do have to transcutaneously pace a patient all the way to CVPH to get a pacemaker placed. And one of our doctors started placing transvenous pacers, and it was a wonderful solution for that particular patient because that patient could not have narcotic pain medicine, and she was able to be transported pain-free with the transvenous pacer as opposed to transcutaneous pacing. And one of our hurdles was we needed a nurse because we are not IFT trained for transvenous pacing. So we did a little bit of research into it, and the doctor who placed it, took me aside and explained how it works. And I thought, this is something we should be able to do because the cure for something going wrong with the transvenous pacer en route is transcutaneous pacing, which is something that we all have that skill for and we've all done. So a transvenous pacer would actually allow us to take a patient a longer distance without as much pain medication or sedation. So in looking into it, we did a little bit of research and thought this is like a viable thing for us to be trained under the IFT guidelines. So I just wanted to put that out there as something that we could possibly study and come up with a training program for. Does anybody have questions?
Not at all. It makes perfect sense if you are an agency that may be required to transport patients that have transvenous pacing. Sounds like a good project to get on and get a training program involved with that. So I don't think it certainly doesn't apply much to Glens Falls, but yeah, that doesn't mean we should exclude it. So I would say go ahead.
Thank you.
Do we have any idea the volume that this would be, or that's really no real sense of that? Because it's an N of 1, what I heard, but perhaps there's more.
So at our hospital, we have at least one doctor, perhaps two, that are placing them. And this has come up with the frequency of maybe one every other month where a transvenous pacer has been placed and we may have to take a nurse or not take the transport. But again, because we transport all the way to Albany and UVM, this would make patients that could not go or tolerate transcutaneous pacing at that distance, we would be able to take them all the way to those hospitals.
One every other month? It's a lot. It's in the water up there.
Not sure about that.
Lyme.
Yeah, Lyme, yeah. It's airborne. Yeah, no, I agree with Dr. Gerling. I mean, it's for remote places, it seems reasonable to do that. Anybody, any other comments or any other questions? So what's the next step for you then? Are you going to come up with a protocol or education packet? What do you plan on doing?
I would like to put together like a training program and suggest it to the IFT committee to see if they would be interested in coming out with a formal training video and program for training paramedics to do it.
Seems reasonable. Okay. Yeah. So we'll await your proposal and get it to the committee when it's ready.
Thank you.
Excellent. Let's see. Next on the agenda, upcoming meeting dates. Do we need to review those? Zach or Jonathan, or are we just publishing those now?
They're just there to remind everybody.
Okay.
May is where it's not the fourth Monday. Otherwise, August and October are the fourth Monday of the month, as usual.
Okay. All righty. We'll open it up for any comments at the moment. Anybody got anything, or should we call it?
So,
right on an hour.
So just to, and Ryan, you can comment further. I don't think nothing's changed as far as I'm aware of, which I might not be aware of. But the last critical care bridge to paramedic has been posted and starts March 3rd or 5th, March 5th. After that, I don't believe there could be plans for additional bridge programs. But when I spoke, that's what I thought. When I spoke to my contact down there, there was not. So I don't want to be bitchy, but this might be one way around. If they don't bridge this time, right, then the only way they can't stay a critical care. So if they can't bridge this round and don't get into a paramedic program, then even though there's not a sunset date, there's no training for them, and you keep. And so my question is because there's no sunset date yet, but there's no bridges left, you're kind of really putting yourself out there if you don't want to be an AEMT. How's that?
Pretty good. I will add one other caveat. There will be no longer any bridge programs, but a paramedic program that chooses to allow for advanced placement would be the alternative pathway that they'd be able to go. So there is still an alternative pathway for those who want to become a paramedic after this. but it would not be through the program that's been established that requires you to do online education with no in-person education. And it would be up to the individual paramedic program on whether or not they wanted to accept it as advanced placement, or if they didn't want to do it at all. There's no requirement for a paramedic program to allow for advanced placement of it.
So I guess and this is just a sore topic for me anyway, but it would be great, I think, in the end, Jonathan, if we could see how many, sorry, Josh, I didn't mean to step on you, how many people we lose that didn't bridge up or go to the paramedic program after next year. It would be interesting just to have that data, I think. It might not be a big number. It would just be interesting to know.
Josh says he has
You can
data,
count me in.
and
Yeah, but he doesn't know yet who's not bridged or who may or may not bridge. That's my point.
yeah, and I think we have a report already built in the system to be able to see how many CCs are running on calls in the big our super region. How many of them that are on these calls are actually performing ALS procedures on those calls, or are they on as a CC, but it was a BLS transport or something like that. So we do have a report built for that. And I think that's a good idea to look at it and compare it as we continue to move forward, and how many CCs there are in the region versus how many are actually active and providing too.
Yeah, and that's the big one that we noticed too, is that there's a number of CCs that are remaining. There's even fewer that show up on a patient care report a year. We don't even necessarily go into too much. And there's even less than that that are performing ALS functions. I think out of the, I think it was like I think we're down to about 200 CCs show up on APCR. It was about less than, I think, 10% of the call volume of things where they needed to do an ALS intervention. And I think it was even a significant smaller number than that had to do an ALS intervention that was not included at the AEMT level. So a lot of it was, they had an asthmatic and they gave a breathing treatment or something along those lines. If I remember correctly, it was literally over the course of 2025, I think there was 4 or 5 times in total amongst all of the CCs that did an intubation or things of that nature that ran a code, like very, very, very small numbers. And from that, we can't necessarily, because it's just very hard to tell, was there a paramedic on scene as well, right? So like, in addition to that, was a paramedic there as well? And they happened to do the skill, but there was somebody else there who could have done the skill as well.
As
Sorry,
we're
my
looking
phone's
at,
overheating.
sorry.
No, my phone is overheating, so I'm just trying to fix that problem here so that,
That happens.
sorry about that.
State issued equipment, No, just saying, from the paramedic original perspective, if we do offer an advanced standing, just so everyone is aware, the advanced standing student will still have to comply with all of our SMC standards, which all of our original students have to apply, which is mostly based around clinical contacts and pieces and parts there. They would be exempt more from didactic time, but they would still have to meet all the same standards set forth in the SMC that any paramedic original student has to accomplish. And that does include clinicals and labs and whatever combination they need to make those requirements occur. So just giving that as a FYI for the group.
And I do believe we are less than 10 right now for the final class. So, and those, the reason that we haven't pushed out or done another one is because the numbers have just significantly dropped down. And there is an alternative pathway. This pathway has been here for a long period of time. So that's kind of where that one fell.
All right. Any last comments or questions before we go? Let me see. I don't see anybody's hand raised. Any other comments? Okay. All right, that'll conclude our meeting. Do I have a motion to adjourn?
Dr. Daly's hands up.
Okay, second.
Sorry, I didn't click the mic. I have a
Oh.
question. Does anyone have any insight into the new federal discussion regarding each agency having their own DEA? Is there anything that the agencies have to do? What's the next steps for that? I've been asked and I am unsure.
You know, can I take that question?
Please do.
God, yes.
So there's a lot of questions going on right now about this one, and to be honest, there's even a lot of questions internally for us. There's 17 states that rule applies towards, which means there's a lot of states that it doesn't apply to. I am actually waiting to meet with my equivalent for Bureau of Narcotics in order to discuss that of, are we a state, are we not a state? If we're not a state, at what point will we become a state, and then what does that mean along that way? So we are absolutely aware of, kind of where this sits right now. We're going to work on getting some answers, and then we'll get like an FAQ out so that you have direct information from both the Division of State EMS as well as Bureau of Narcotic Enforcement. So just there's no immediate needs that need to be addressed. It's just purely upcoming.
Perfect. Thank you.
Absolutely. Great question.
Is it something, so is it gonna come no matter what, and it's a matter of timing, or is it may come, it may not come?
I'm not sure. Like I was actually caught off guard because when we were told about it at our, so I was told 2 years ago now at the National Association of State EMS Officers, actually the DEA came in and spoke to us directly about this transition. They said to bear with them. They said, and literally, jokingly, but not, they're like, if you think state processes take a while, come join us on the federal side. They take even longer. And they weren't kidding. 2 years later, when they told us it would be like 2 or 3 months, is when the ruling came out. So, from that point of view, I was caught off guard, and it doesn't apply to every state right now. And I'm trying to find out why it doesn't, both for ourselves in New York, but also I sit on the national board now, so that we have answers at that level. And so we're, kind of flushing through some of that right now too. So I will have more of an answer for you in a little bit, because I was even caught off guard that I thought it was sweeping, right? I thought it was going to be across the country. This is what it is. Turns out it's across the country-ish.
All right. Okay. Any other comments? Going once? All right. With that being said, do I have a motion to adjourn? Okay. Second? All right. All in favor? Anybody opposed? All right. Thank you, guys. Good meeting. See you guys later.
Have a great